great. Thank you so much for the invitation. And yeah, really happy to be sharing some of the work that was from my PhD. So yeah, I'll be talking about a bit about the work, the results, so the impact of it, and a little bit about the data sets as well, which might be helpful for the audience here who may not be aware of some of these data sets that aren't some of the more common ones used in health data research. So that's myself. That's a nice picture of Leicester. And of course, there was a wider team of my supervisors and people who contributed to this, who I'll mention at the end. So my background is as a neonatal subspecialty registrar. And in paediatrics, we go through, we rotate through neonatal, paediatric, critical care, and these different areas. And in the last few years, we've been looking after more and more babies sort of born on the threshold of viability. You know, we're trying to resuscitate and provide intensive care to smaller and smaller babies. And as I say, for a non-specialist audience, I'll be talking a little bit about this background to set the context. So this is baby Imogen. This is sort of anonymized case, baby I looked after, just born at 22 weeks, weighing only 0.5 kilogram. And she had a long stay in the neonatal intensive care. She had complications, including surgery for bowel inflammation infection. She had chronic lung disease and was on the ventilator for a long time. But eventually she was discharged from the neonatal unit, which is against the odds for the gestation she was born at. However, I moved on to paediatric intensive care as part of my rotation, and she had an unexpected deterioration and was admitted to paediatric intensive care and reventilated. And, you know, the family had been through a lot of trauma, had a lot of some mental health symptoms as a result of the neonatal journey. And then to experience this unexpected deterioration, end up back in an intensive care situation was really a lot for them. And so this is a sort of one of the cases that made me think about going and doing this research and pursuing this. Just a little bit more about the neonatal care and paediatric intensive care. So neonatal care is for preterm and sick babies after birth. And there are almost 200 neonatal units in the UK, and there's different levels. At Leicester, we have the highest level intensive care with surgery on site as well. And then we have smaller special care baby units in smaller district general type hospitals. And they provide care, as I say, for the preterm and sick babies after birth. But outside of that period after birth, we have paediatric intensive care to provide intensive and critical care for children of all ages. And there are fewer, there are only 30 PICUs in the UK, depending how you count some of them. And they provide things like trauma care for if the children that have road traffic accidents, cancer care, cardiac care, care for babies or children who become unwell with infections, and you know, a whole range of other neurocritical care. So it's a really wide-ranging field, although smaller and relatively niche compared with some of our adult colleagues in adult intensive care. Obviously, this is very important, and the impact of how we look after children in the neonatal and paediatric has implications for the whole of adulthood. So when talking to families who ended up in these situations where they were in neonatal care and then later end up in PICU, they say PICU is like being thrown into a different environment. They told us that PICU is 10 times more intense than neonatal, and you don't expect it will happen, PICU admission, when they go home from the neonatal unit. And you can see just from these photos here, again, for those who aren't familiar with it, you can see in neonatal care, we tend to have the babies in these Perspex sort of incubators, and then they tend to be in open cots. Even a baby who's just a few months old will be in an open cot, and there may be a teenager next to it, the baby, and it can be a lot more noisy. So parents do find it quite traumatic being thrown back into this intensive care situation. From a wider perspective, some of the work we did, I'll just sort of preempt some of the discussion we go on to. Of all the children who are neonatal, how many go on to PICU? And this could be because they have a cardiac condition and need surgery, abdominal condition, or they go home and come back. But overall, our babies on neonatal unit, 5% see a PICU and admitted to PICU before 2 years of age for any reason. I say it can be lots of different reasons, cardiac, respiratory. But in the paediatric intensive care, half of the children and babies they see have been through neonatal unit. So our perspective on neonatal is that we think we do quite well. Our children don't have any intensive care after they go home. But in the paediatric intensive care, half of their children are the graduates, if you like, from neonatal units. So they feel quite strongly that they're looking after the same babies as we do. And that's a result of there being fewer PICUs, so they're sort of concentrated. So the research question that really wanted to answer was, when a preterm born baby leaves neonatal care, what's the risk they'd be admitted to PICU? Focusing on these very preterm babies born less than 32 weeks. So to do this, we created a retrospective cohort study from birth up to the age of 2 for the birth cohort born 2013 to 18 across all of England and Wales, all very preterm births. And we could follow them till neonatal discharge and then get our information from the National Neonatal Research Database, which I'll touch on more in a second. Follow to the age of 2 and then pick up any paediatric intensive care admissions through PeakyNet, which I'll touch on in a second as well. I'll tell you a little bit about these data sets. And NHS Digital, as was, provided the data linkage between the two with pseudonymisation. So pseudonymised data was provided to us at the University of Leicester. So the NNRD was established in 2007, and there's been complete data for England, Scotland and Wales since 2015, so 10 years now, of all neonatal admissions across the whole of the mainland UK, and we're developing in Ireland as well. And the principle is enter high quality data once and use for multiple outputs, which I'll touch in a second. But the NNRD receives data from Neonatal Badgernet, and again, for those who haven't worked in neonatal care, this is the EPR system that is generally used for admission and discharge, and also for daily care information. So the level of intensive care, any interventions that are done, like ventilation, all of these things. And all of this data is collected in the NNRD and hosted in Imperial College London. There's 400 plus data items per baby on all neonatal units, so it's very rich data. If you compare it to something like HES, it's high quality, it's very rich, it provides daily interventions and levels of care for the baby. And there's also quality assurance and data cleaning. And you can see just how many babies there are now, so over 1 million babies are in the data set, and it's going up all of the time. And access to an NRD is through the HDR UK Innovation Gateway, and then subject to ethics and costs for maintenance of the NNRD. So the idea is that the UK Neonatal Collaborative, all the neonatal units, enter routine clinical data into the Badgernet system. It's collected and then used for different outputs, so research, but also audit and benchmarking quality improvement. And they've used at a local and regional and national level. It's used. There's also been some developments with how the data is visualized. So if you go to the NNRD website, you can see this live Power BI dashboard that gives you information about, so here we have the birth weight distribution all around the country, the gestational age, so 40 being term babies around their due date, and the preterm babies there on the left. And also there's a data hotspot map, and you can see in the Midlands, you've got a big red hotspot around all the births focused around Birmingham and the Midlands here, and London, Manchester and Bristol and South West. And you can also get survival details and outcomes. We also have PeakyNet, so this is the other part of the data linkage. So PeakyNet is hosted between the University of Leeds and the University of Leicester. So in the office I work in are PeakyNet staff. And PeakyNet's had full UK coverage since 2008, so 20 years coming up, 20 years of data, and then coming up in the next few years will be 20 years of full UK coverage. And again, it's very rich data set, again, compared with HES. You have all the admissions, all the discharges, and daily interventions across critical care. And also it has a PICU transport episodes for those who are interested in how critically ill children who are present in a district general are retrieved and stabilised and transported to intensive care. And again, there's data verification and cleaning. Access is through HKIP. They have their own internal approval systems, and there's costs required as well. And PConnect is used again for annual reports. The PConnect State of the Nation was recently released. Audit data dashboards, which you can get online from PConnect's website, and extensive research as well. And you can see that there's other linkages being developed. So in Imperial, they're developing a NeoWonder, which is a linkage between the NNRD neonatal data and education and health data. So they'll be able to look more in depth at what the school age outcomes in terms of special educational needs, exams, all of these things for our preterm and sick babies. So that'll be really exciting in the next few years to see the team with Cheryl Battersby down in Imperial having papers coming out of NeoWonder. So that's a bit background about the data sets. So just returning to what we were doing as part of my PhD and the other NIHR funded work. So we created this birth cohort where you could pick up the PICU admissions. So how many were there in this 2013 to 18 birth cohort? You can see there's over 46,000, so we had good numbers using this national data. There were some exclusions for babies who died in neonatal care or discharged directly elsewhere without going home, and a small amount of data cleaning. But you can see overall it's quite a clean data set. There were over 40,000 babies who discharged home, thankfully. And then we found that it was 2,300 PICU admissions. So how does that look as percentage? So here I'm presenting the data by gestational age at birth. And just to remind you again, 40 is the full-term pregnancy. So you can see 31 down to less than 24 are smallest babies, like we talked about Imogen at the start. There are more babies who are at the 31 and then relatively few at the smallest end. But you can see that the proportion who have PICU admissions is 5.7 overall, but it varies very much depending on gestation, with higher up to 13.6% for the smallest babies. And why were babies admitted? So here you can see a Sankey diagram of the PICU admissions. On the left, you have all the ones. So this is the first admission. The majority, around 80% of the children and babies, didn't have a second admission in grey, but then 20% did have a second admission, and you can see for third admission, and some of these children even go on to have 4th and 5th admissions. The main thing to look at is the biggest, which is blue. You can see respiratory. So over 60% of the first admissions were respiratory reasons, and you can see that follows on with the repeat admissions. Although interesting, there's a number of children who might have presented with neurological problems and then readmitted with respiratory problems another time, suggesting there's children who have multiple pathologies and multiple long-term conditions affecting them. We also wanted to look at whether these PICU admissions were elective or planned, or were they unplanned emergency? Because I think there's a big difference for families if they know that, say their preterm baby has a hernia, inguinal hernia, and they're going to need that repaired as a sort of routine thing in the next couple of months. And because their baby was very small, they have a PICU bed booked post-op. They might get a chance to look around the PICU and they're expecting it. That's going to be quite a different situation than if the family go home and their child gets a chest infection or a virus and goes to their local A&E and deteriorates and has to be blue lighted by PICU transport and ends up in a PICU in a city far from home. That's going to be a very sort of different situation for them. So here we have the percentages again for how many children had these PICU admissions and then how many were unplanned. And you can see the majority, about 80%, are unplanned across all the gestations. So most of these are these situations where families aren't expected to come back to intensive care. Then doing a Kaplan-Meier cumulative incidence curve of this data, where you have it broken down by the gestation. So at the top, you can see the less than 24-week smallest babies and the slightly bigger 31-week babies at the bottom. You can see that the steepest part, if we look at the days since neonatal discharge, is at the start. So if we just say as a roughly 72% of unplanned PIC admissions happen within the first 100 days of discharge. So we can identify that when we're sending babies home from the neonatal unit, this is the highest risk time for those babies for bouncing back and needing intensive care. We also want to look at a little bit about morbidity. So I said about some of these babies having long-term neonatal brain injury from bleeds on the brain, long-term lung injury, which we call BPD, bronchopulmonary dysplasia, and NEC, necrotizing enterocolitis, so gut infection and inflammation that can require surgery and excision of affected areas of the gut. Some babies have stomas for that. So here we have again the gestations, the smallest babies on the left, which is 23, 24, and the bigger babies, which is 30, 31, and the rate of unplanned PIC admissions before the age of 2 years. And in this model, we've broken down by morbidity. So the predictions if you don't have any major morbidity on the bottom line. And then you can see the next one, regardless of the type of morbidity, so the brain injury, the chronic lung disease, or the gut surgery, all have a similar increase in risk. And then if you have 2 in any combination, these have a similar increase in risk, and then 3. So you can start to see that there's effect of multiple long-term conditions from the neonatal period have a significant impact on the future risks of intensive care for babies. What were the outcomes in PICU? So fortunately, PICU survival has improved as the decades have gone down. And for this group with respiratory conditions, actually the majority of children, thankfully, go home and recover. So mortality is only 2.4%, which is in keeping with the broader figures for PICU for respiratory admissions. More concerning was this readmission figure, as I touched on before. So over 20%, so 1 in 5 children who were admitted to PICU come back again before their 2nd birthday. So there's, again, quite a lot of long-term critical illness concern about this. So the conclusions from this stage were that over 1 in 20 children born less than 32 weeks need PICU admission after going home from the neonatal unit. Most of them are unplanned, most of them are these respiratory admissions. And for the higher risk babies, this increased to over 1 in 10. We may be able to think about this on our neonatal discharge planning, particularly because these tend to occur shortly after babies go home. And we need to work with families to communicate this risk in a way that's personalised to the family and their desires for how much information they want, which varies a lot between some families who want all the statistics and some families don't want to know. So with this in mind, we developed infographics which were co-designed working with families and neonatal healthcare professionals, available online through this link. And these are for hospitalizations and for PICU. I'll get onto the hospital data shortly. So this can be used by neonatal units. And I know that Bristol in particular have introduced this as part of their routine discharge planning to have this data available. We also developed, working with Ting Chan Kwok at the University of Nottingham, a preterm outcome dashboard. So this is a dashboard for a range of preterm outcomes that Ting has put in, and then we've contributed the PICU data. You can see that you can input gestation, the birth weight, different morbidities, the sex of baby, and then you can see the predictions for these range of outcomes. So this is more for professionals. And again, that's available freely online. We also, sort of doing this work, identified this issue that children are having a transition between the neonatal and paediatric care, and this isn't always as smooth as it could be. And so the British Association of Perinatal Medicine, who represent all the professionals working in neonatal perinatal care, came together working with Paediatric Critical Care Society for a new BAPM working group on transition to paediatrics. And the draft framework for this for the country has gone out for consultation. So it'll be interesting to see the responses to this and how this develops in the future. So following the thesis, I had some extra questions that I wanted to think about that I'd like to share as well. And all of these are in open access papers now, they're all published. So does going home from neonatal care in winter instead of summer make a difference? And that probably makes intuitive sense because we know that winter's the time when the NHS is under pressure with flu, and we also have RSV, respiratory syncytial virus. Just coughs and colds can result in children becoming unwell. So we were able to create a model looking at the hazard ratio over the different months. And due to the way that the risk worked, we need to develop a flexible parametric model, because if you go home in September, if you think about it, the kids start back at school, they've got a higher risk, even if it's not higher immediately, because they've got to go through all of autumn and then winter and then spring before coming out. So the cumulative risk is higher than if a baby goes home at the peak of winter, say in December, January. At least spring is coming around the corner. So it was quite interesting, actually, that the peak was in this autumn term time. So if we use those to then create model predictions, say for the smallest baby, their risk is about twice as much in this peak end of autumn into winter time as it is in the summer months. So this adds another aspect to consider when thinking about talking to families around neonatal discharge. You know, what time of year is it? And similarly for our bigger babies, we could see, again, the risk more or less doubles when you're in that autumn going into winter time, that peak risk. And what about hospital admissions, not just PICU? So, you know, obviously it's most devastating families going back into intensive care, but it's going to disrupt families a lot, even just going into hospital, even just to the paediatric ward is still a big deal. So we were able to link again with the HES data, NHS hospital episode statistics, admitted patient data, and also the Welsh data as well. And here you can see that, just briefly, if we look at any hospital admission across the whole cohort of these children born less than 32 weeks, 67% had at least one hospital admission between neonatal discharge and the age of 2. So 2/3, the majority. And again, you can see that it goes with gestational age. If we go to the smallest babies, we're approaching 90% of babies have any hospital admission for any cause. And again, are they emergency? Again, you can get that from the HES. And again, you can see that the majority of these are emergency hospitalizations. And again, you can look at the admission coding for HES, the ICD codes, and you can see that respiratory is the most common. So it mirrors the ICU data, but these children are less severely affected. We also wanted to explore, again, think about the morbidities, whether having multiple neonatal morbidities leads to an increased hospitalization. And we did this with the total time hospitalized in days. I mean, generally children had quite short hospitalizations of just a couple of days in paediatric assessment unit on the wards, but a minority of children had very long hospitalizations. And again, you can see as you go from no major neonatal morbidity and you increase to 1, 2, and 3, the number of days that the model predicts the children will stay in hospital increases, and increases with the gestational age. So for the smallest babies who have all of those morbidities, these things that will have lifelong effects, like the brain injury, lung disease, having gut surgery, you may expect they might be in hospital for up to 50 days, even after going home from neonatal care. But they're relatively small numbers, so our confidence intervals do widen at that point. So again, what were the conclusions from this area's work? So most very preterm babies have at least one hospital admission after going home from neonatal care. So this is again something important to discuss with families, that they can probably expect they are going to come back at some point. And we did look at season as well, and season has an effect as well. Most of these are unplanned, mostly for respiratory, but thankfully mostly for short duration. But there are some very preterm children with long-term morbidity have longer admissions, and discharge in the autumn and winter is highest risk for both intensive care and just hospital admissions in general. Now, something that should change this is we provided this data to NHS England when they were considering the immunisation programmes, and the new nirsevimab programme for very preterm babies has been rolled out. We're doing it in Leicester, and this should reduce the risk. This is a monoclonal antibody given for RSV, respiratory syncytial virus. It provides protection for at least one season, perhaps two. And we're seeing around the world that in high-income countries that have rolled out nirsevimab, the number of paediatric intensive care admissions is going down, which is great. We know in the UK that our decision was to give maternal RSV prophylaxis around 28 weeks. But the problem was that this wasn't going to protect our very preterm babies, because some of them were born before the moms had their RSV immunisation, or they were born shortly after and didn't have time for the antibodies to transfer through the placenta to baby. So now, even if babies have missed out on the maternal benefits, they will get the nirsevimab. And what's good is that having this information can help with talking to families, in that we can say that if we don't have the nirsevimab, we know this many children similar to your baby will have hospital admissions. This will have PICU, and I say the majority will have hospital admissions, and we know that nirsevimab can reduce this. So hopefully, actually, the data will start to go out of date if we see this new rolling out, and actually we have less admissions. That'll be really good to see. But it was great that we could contribute in a small way by providing some of the data to NHS England to help with decision making for this. So what's next? So following on from this, in my NIHR Clinical Lecturer role, I'm doing the MAPS study. So this is looking at multiple long-term conditions more widely and the impact of prematurity, using CPRD and HES data to look at primary and secondary care, and to think about how we classify paediatric multiple long-term conditions, and how in the first 10 years of life preterm birth might affect this. And here we've got there's a lot of them throughout. We've got some of the children who've contributed to the PPI work throughout my work, through my PhD and beyond. So you can see some of these children who are living with multiple long-term conditions, but still obviously getting out and enjoying themselves. And then we have eChampions. This is a proposal that I'm submitting to funders at the moment. So this is enlarging it again. So think about that first decade of life, multiple long-term conditions in children across England and Wales, but also thinking about their education, a bit like Near Wonder, but thinking more broadly how we can improve the services that we offer for children with multiple long-term conditions. And here's a drawing that one of the children have provided that will make up the logo for the eChampion study. This QR code goes to an online form that asks healthcare professionals and academics how they think, if they're interested in child health, how we should classify multiple long-term conditions, because it's still something that's not really come together and formed into sort of a coherent definition as it had with adults. And there's a lot of debate about how many conditions we should include, whether it's tens, hundreds, or even thousands, up to rare conditions that we include in our classifications. So that link is available for anyone who wants to contribute, who's interested in child health. So yeah, thank you to my supervisors, particularly Dr. Sarah Seaton at Leicester, who's now the PCANET lead, and her NIHR Advanced Fellowship sort of contributed to a lot of this work. Funders, Bliss and charities worked with, and the families who've contributed their data and contributed to the PPI. So Ava's mum, Josh's mum, Oliver's mum. Thank you very much. Happy to take any questions.